Okay, next condition is septic arthritis, and you need to understand septic arthritis. To just give you a little bit of a background on this, this condition is so important. What I used to do was I was a patient simulator for the Canadian Medical Council. So I would go in and simulate different conditions for doctors attempting to get their licensure in Canada from other countries, or students also going through and completing their fourth year and into their residencies and getting their licenses as well. And one of the cases that we would run would be a septic arthritis case. If you don't pick this up, number one, it can lead to full joint failure. Number two, it could lead to actual necrosis and even death if it's not picked up early enough from sepsis in the body. So septic arthritis of the hip, for whatever reason, the research isn't clear on this, why the bacteria Staphylococcus likes to grow inside of that hip, but it's a common location to see it. So what happens? Bacterial infection in the synovium and inflammation around the hip. You often get purulent effusion. The joint capsule swells up. It's known as multiple different names like bacterial arthritis, infectious arthritis, septic arthritis. Bacteria gets into the bloodstream. And for whatever reason, a puncture wound, you'd be only looking for that in the lower extremity potentially, or little cuts in the legs. The bacteria grows, it causes a little bit of inflammation and toxic byproducts. These lead to the feeling of pain deep inside the hip. Staph aureus is the most common one that we're going to see growing in there. And this can happen in kids. Okay, hip involvement is most common. Knees are possible as well. 40 to 50% of joint infections are in the hip. Okay. So incidence, it is not overly common, thankfully, but it is something that we have to be aware of. General population, 2 to 5 in 100,000, so pretty rare. More common in children, they're falling and getting cut all the time. More common in rheumatoid arthritis patients who may be slightly immunocompromised. More common even in prosthetics as well. The rates go quite a bit higher there, but still relatively rare. Any age group, more common in elderly, but can happen for anybody, okay? Males slightly greater than females, but it might just be due to activity levels and being out there getting cut up and damaging themselves a little bit more. Risk factors: diabetes, joint replacements, skin infections, previous septic arthritis, intravenous drug users, because we can see it's a direct application for how the bacteria can get in, rheumatoid arthritis, recent injections, potentially following surgeries. If you're immunodeficient, blood bleeding issues, sickle cell anemias, maybe a cancer under there, and low socioeconomic status, all are increased risk factors for this condition. History: sudden onset of joint pain. And let's be clear on this sudden onset of joint pain. It can be tricky because this person could have been doing some kind of athletic event. They're like, oh, I just tweaked my hip a little bit. But it gradually progresses throughout the day. So maybe they don't actually have trauma and all of a sudden they just woke up with hip pain or something like that, okay? And it gets worse. They're starting to feel a little bit fatigued. Maybe they've got a little bit of cough, runny nose, all of that kind of stuff, right? There's another infection. Their temperature may be higher, above 37 degrees. They've got an antalgic gait. Now, this redness is interesting when you're doing your inspection. Hip joints are deep. It is difficult to see an infection on a hip joint. I'll give you my own story here. I was bit by a spider, and I did not turn into Spider-Man. But I was bit by a spider and I could see the two puncture wounds right here on it was actually this forearm right here, on my forearm right there. And what happened is you could see the infection starting to form. So my wrist got a little red bump on it. You could see the lymphadenopathies running down, where you could see the streaks running all the way down my arm like this. And the infection was traveling through that tissue. Now, I felt like crap with it. So what actually happened was I had to go and get antibiotics. We went in and we aspirated it. So I took a needle, jabbed it myself, and just the most mucal purulent pus was draining out of the front of my wrist where this bite actually was here. I had instant relief once that pus pressure was taken off. In the hip, that is exactly what's happening. This bacteria is laying down all these byproducts in there, and it's increasing pressure inside of the hip. So as it gets worse, this person will have multi-directional loss of range of motion due to pain. So possible puncture wounds, look for those in lower extremities. Palpation, heat, tenderness, local swelling of lymph nodes. Evaluate that femoral triangle and look for the enlargement of the lymph nodes or tenderness there. Those femoral lymph nodes are key. Clinical prediction rule for this: history of fever, non-weight bearing. They don't want to squeeze the joint capsule or stimulate that tissue. An ESR over 40 millimeters an hour, or serum white blood cell counts that are higher. And you can see here, if I have 4 of these, you are 99% sure I have septic arthritis. Even if I have one, you're still in that 25% range. It's still worth doing more detailed evaluation. You're probably going to do the blood tests and everything else because of the second, if you have two of these factors. If you just had a history of a fever and you don't want to bear weight, that's enough. You're going to the ER to have this evaluated. Okay. All right. Differential diagnosis, transient synovitis, usually a younger person, usually self-limiting. In septic arthritis, it is progressive throughout the day or days. Okay. Local sprain strain potentially, but there should be a mechanism of trauma for that. Inflammatory arthritis, they probably already know they have lupus or rheumatoid arthritis. OA, if you're in the geriatric patient population or prior injuries, benign or metastatic cancers, unexplained weight loss, other risk factors there. SCFE, you look for your right age group. Avascular necrosis, gradual onset, doesn't really fit too well. Leg calvi purse, same thing in a kid. And pain referral from the viscera, well, that should look like a visceral referral, right? Difficult to localize, other GI complaints associated with it. Anvil tests, yes, would be one of the tests. And we were running this for the Canadian Medical Council. Absolutely, the Anvil test was there. If somebody has septic arthritis and it's advanced, they won't even let you pick the leg up. You should just put their leg flat on the table, give it a little tap in whatever position they feel comfortable, and it'll usually light them right up right there. All right, diagnostic imaging, X-ray is only useful to rule out other pathologies. You are not going to be able to see the septic arthritis. You might see the joint space is a little bit larger on the affected side, but that is a non-specific finding. It doesn't really help you that much. You're going to be looking way better at an ultrasound if you have not a very thick thigh and you can get in there with it in a good quality ultrasound unit, or MRI is going to be your best choice. And on this MRI right here, I color enhanced it so you could see it even better. But if you're looking at this, this is a normal joint. There is synovial fluid and cartilage filling up that space and that little white signal right there. And this joint has got whiteness all the way around it that shows us there is more effusion, more swelling inside of that joint capsule. So MRI is going to be by far your better choice. You're going to have a white blood cell count done. You're going to do blood tests basically for white blood cell, red blood cell counts. You're going to look for elevated ESRs, C-reactive proteins. Again, not specific, but indicate inflammation, and joint aspiration and culture. But by the time you're there for the joint aspiration and culture, you might as well be treating with antibiotics as well at that time. Again, not in our typical outpatient office. We have to recognize you've got a fever, you're not weight bearing, you're not moving this in any direction, and it doesn't really follow the pathway of a standard sprain strain or anything. We need to send you somewhere else. Okay. Immediate hospital referral is required. Drainage of the infected synovial fluid is needed, and administration of local antibiotics into the joint are going to result in better outcomes. In recalcitrant, nasty cases where it doesn't go away, you might have to go in there and they'll even have a draining tube and stuff, but those are people who are often immunocompromised or have recurrent infections potentially. After this is all taken care of, we still have lots to offer in our outpatient clinics. We can go ahead and get you through mobilizations, massage, motion, all the standard stuff that we would do, swimming, water aerobics, gentle biking, all of those are going to offer benefit as we build up your strength. But the key thing to recognize for this condition is that you recognize it early. Speed and accuracy of diagnosis is key to the outcome. If you catch it earlier, like literally every hour the bacteria has to grow, that's more cartilage damage, it's more damage inside of the joint that took place. That's going to delay the healing process for this person. 50% of adults with septic arthritis have significant side effects or decreased range of motion or chronic pain after the infection. So be aware of this. If I catch it earlier, I can lower the likelihood of this happening. Predictors of a poorer outcome if you are over 60 and have coexisting rheumatoid arthritis. If the synovial fluid cultures after 7 days of appropriate therapy still has the culture in it, you are having a long-term infection. That is a tough case right there. All right. Yeah, earlier diagnosis is key. Medical legal issues would be this person comes in, you're like, oh, you just got a hip sprain or you've got some kind of groin strain or whatever else you called it. It progressed again, and you misdiagnosed this condition earlier on. That would be medical legal issues potentially on your side. All right, so what can we do for rehab afterwards? Basic range of motion is going to be key, working our way towards getting these people back to good lower body functional strength with their ability to squat. But septic arthritis, please just don't miss it. And again, focus on these clinical prediction rules right here. History of fever, non-weight bearing because it's too painful. You don't want to move it, and it's multi-directional. You don't want to move it. then that's enough for me to say you're going to the ER. There's already about a 70% chance you have septic arthritis just with those two right there. Okay. If it was a sprain strain, usually it's unidirectional. It's one motion that makes it worse. In this hip septic arthritis, it's all the directions. They don't want to move in any single direction. That's kind of your giveaway right there. Really good condition, important for us to understand. Thank you so much for taking the time to watch this, and we will see you on the next video. All right.